Welcome, everybody. I'll start here in just a moment as everybody drops into the call. Hello, everyone out there. I am Dr. Jeff Katzman, the Director of Education here at Silver Hill Hospital. Welcome and thank you for joining us at today's virtual grand rounds on cognitive behavioral therapy for insomnia. In a moment, I will introduce our guest speaker, Dr. Lynelle Schneeberg. But first, a few housekeeping details. First off, we would absolutely love to hear from you. And this topic, I think, is one that we can all relate to. So at the end of the lecture, we'll have some time for questions, and I welcome comments as well. To submit a question, please do so at any time during the presentation using the Q&A link at the bottom of your screen. We will get to those questions then at the end of the presentation and have a conversation as we've done in the past. For anyone wishing to receive CME or CEC credits, please complete the evaluation survey that will automatically pop up in the browser when the webinar ends. Also, we'll email you a copy of the survey following the presentation. Finally, disclosure, no Silver Hill Hospital planners of this activity have any relevant financial relationships to disclose in relation to this presentation. It is now my absolute pleasure to introduce Dr. Schneeberg. Dr. Lynelle Schneeberg, PsyD, is a sleep psychologist and assistant professor at the Yale School of Medicine and the director of behavioral sleep program at Connecticut Children's Medical Center. As a fellow of the American Academy of Sleep Medicine, she is one of only about 200 board-certified sleep psychologists in the country. She enjoys helping adults with insomnia learn how to get the quality sleep they need, and she also works with parents of children who have sleep difficulties. She's the author of Become Your Child's Sleep Coach, the Bedtime Doctor's 5-Step Guide, ages 3 to 10. Which she wrote to help parents of school-age children teach their children to be great sleepers. I've looked at these slides ahead of time and I'm very excited and joked with Dr. Schneeberg that I'm looking forward to a good night's sleep following the presentation. So Dr. Schneeberg, I hand the baton to you and thanks again so much for being with us today.
Thank you. Thank you so much for inviting me. And I hope I deliver on that wish. I do hope that all of you have some ideas by the end of this presentation on how to improve your own sleep and members of your family and of course your patients. All right. So the same disclosure that Dr. Katzman already reviewed is true for me. And I'm going to start with just a quick overview, right? We'll talk about adult insomnia first, the 3 types, the 3P model, the case for cognitive behavioral therapy for insomnia, and then, evaluating insomnia, treating insomnia. And then I've included some tips that I hope will bring you some great sleep yourself. And then if we have time, we're going to also talk about childhood insomnia. And I'll give you an overview of that topic and some ideas about how to improve the sleep of children too. Okay, so insomnia has many potential contributing factors and symptoms, but the 2 components that we always want to look for are sleep difficulties that occur despite an adequate opportunity for sleep. And the secondary part includes daytime impairment. So there's usually some kind of daytime impairment that the patient will report if they have insomnia. And 30 to 40% of adults say that they have symptoms of insomnia within a given year. And we would term that acute insomnia, but then 5 to 15% of them go on to develop chronic insomnia. And that's really what we're going to focus on today, chronic insomnia. There are 3 types of insomnia and they can coexist, of course. So trouble falling asleep, sleep onset, trouble staying asleep, sleep maintenance insomnia, and early morning waking. Again, most people have a combination, but usually they struggle more so with one area of those 3. And then there's a very useful model that I always review with patients, and it's called the 3P model. It was developed by Dr. Spielman, and it's not a curative model, but it's an explanatory model. And so it goes like this. People who eventually develop insomnia often have predisposing factors, if you will, risk factors. So it might be genetics or wiring. And what I mean by that would be someone who's sort of a type A personality, a worrier, a perfectionist, high achiever. So that person in a way is at risk for developing insomnia, but doesn't have it yet. And then the precipitating factor comes in. The stressful event occurs, can be anything, could be loss of a job, could be the health of a family member. And then that person does indeed have insomnia. And then when that event is better, improves, time goes by, then the person might still have, though, perpetuating factors that keep the insomnia going. And these are behaviors that would cause the insomnia to stick around. And that might be, for example, let's say that you did lose your job. You might stay awake longer than you normally do, or you might become really worried about your job and then you might sleep in on the weekends. There are all kinds of things that you might start doing, including maybe even using your bed for worry. So there are a lot of things that you can do during that stressful event that then will cause the insomnia to persist after the precipitating factor is improved. So CBTI is what we're going to talk about today, of course, cognitive behavioral therapy for insomnia. And I love my job so much because it's such a helpful therapy. 70 to 80% of patients with even very long-term poor sleep benefit from CBTI. The treatment is reliable and durable, and there have been hundreds and hundreds of randomized controlled trials. This journal article is from 2004, so you can imagine how many more have been done in the meantime, and they all show the benefit of CBTI. There are really good long-term outcomes. 80% of people learn these skills and maintain their gains, and CBTI can be used for many things, but CBTI programs for insomnia are even more successful than those for other things like weight loss and smoking cessation. And long-term nightly sleep med users, the average was a 19-year history, were able to eliminate their sleep med use altogether using CBTI and some gradual tapering protocols. We'll talk about those tapering protocols in detail. And it's the opinion of me and the American Academy of Sleep Medicine that CBTI should be the first line treatment for insomnia. It's more effective than sleep medications, more durable, more self-driven, and it's the practice standard. So I'll start with a case example. This is Sarah, and Sarah is a 62-year-old with a multi-decade history of insomnia. She has mind racing and clock watching, along with a very complicated medication regimen as follows. So at 10 p.m., she was taking 1 milligram of diazepam, over-the-counter valerian, and 20 milligrams of melatonin. When she awakens at 1 a.m., which she almost always does, she takes Sonata or Zalopon and moves to another bedroom so as to not disturb her husband. She awakens again around 4 a.m., takes more diazepam. If she can't go to sleep at 4 a.m., she'll go downstairs to meditate or read. And if she gets sleepy again, she'll return to her second bedroom and get up by 7 a.m. When she came to me, she was very motivated for CBTI. She really wanted to learn how to be a good sleeper and taper her meds. But even during the very first session, she asked me whether I would want to recommend a different medication for her, which is very, very common for people with insomnia. They're always looking for what I call, the magic potion, the magic combination of things that will help them become a great sleeper. And some of them develop these very complicated algorithms for what they're going to do at bedtime and what they're going to do in the middle of the night, and so on, just like Sarah. So when we're ready to evaluate insomnia and it's time for me to do my job, I'm going to look at the person's medical and psychological history, of course, as the background. And then I'm going to evaluate the following things. What are their sleep skills? Can they relax? Do they know how to relax? Do they know how to turn off what we often call busy brain? It's called excessive mentation at bedtime. People say, I can't turn my brain off. There's a lot of ways people put that, but it's extremely common for people with insomnia. And then what kind of sleep habits might they have that might lead them to have insomnia? What is their sleep environment like? Do they have environmental issues that worsen sleep? And by that, I mean everything from where do they live? You know, do they live in the center of New Haven where it can be loud? Do they have a husband who snores? Do they have a teenager who comes home late? Do they have a dog, an older dog that needs to go out? Do they have a baby? Do they have young children? Which is, of course, my own special interest, young children who don't sleep well and then disrupt the sleep of the entire family. What about electronics? The constant question that we get about electronics. And then habits in the daytime. What kind of daytime habits might they have that worsen their sleep? And then do they use sleep aids? How many? What kinds? And do they want to taper them? So this is the time in my talk when I switch gears and do a little quiz, which you can take yourself as we're going along. So let's act as though I'm going to evaluate your sleep. Here's the things that I would look at, the same things we discussed, right? Cognitive sleep skills, habits, environment, electronics, daily habits, and use of sleep meds. So here we go. I want you to think about whether you would find these statements to be true for yourself. I do not feel good about my ability to fall asleep or stay asleep. When I can't sleep, I lie in bed trying to sleep for long periods, and I am not good at turning off busy brain at bedtime or during the night after an awakening. So if you answer true to some of those, then you would want to work on your cognitive sleep skills. The next one would be your sleep habits. I do not have a bedtime routine or buffer zone between work and sleep. I ignore my drowsy feelings at bedtime to accomplish a few more things. I clock watch. That's very common behavior for people with insomnia. I check the time frequently, in other words, when I cannot sleep. And then I always say, some people even do what I call the math. So they will wake up at 1 o'clock in the morning and they'll think, oh, how long have I been asleep and how much time is left? And I wonder how long I'll be awake. And I wonder if I'll wake again. And they'll do a lot of math about their sleep at night. After I get to sleep at bedtime, I get up later to eat during the night. I find that nocturnal eating is something that a lot of physicians and providers do not ask about, and it's quite widespread. Many people wake up and they're bored and they're frustrated and they're anxious, and they might go to the kitchen and have something to eat. And then that sort of relaxes them and they go back to sleep and go back to bed and go to sleep. The problem is you can definitely train yourself to be a night eater if you want to. And that becomes sort of a Pavlovian response. You know, I have to wake up and go to the kitchen and eat in order to get back to bed. And that's a pattern that most people don't want to build. But many people do build that pattern. And so I always ask people to think about that. My bedtimes or rise times vary by more than 2 hours from the weekdays to the weekends. That is not true for good sleepers. So I'm always looking at bedtimes and rise times and how consistent they are. And then I'm in bed for more than 8 or 9 hours each night, or I'm in bed awake a lot. I nap at odd times of day. And by that, I mean morning or evening, and for more than 30 minutes. So if you answered true to some of these, then we would take a closer look at your sleep habits. Your sleep environment. Is your bedroom quiet enough? Is it cool enough? Is it dark enough? And again, do you have some of these environmental issues, partners, roommates, pets, children, disturbing your sleep? Electronics, something I get asked about almost more than anything else. So I would want to know if you turn your devices off an hour before bed. I would want to know if you use your cell phone or your computer or video game in your bed at bedtime, whether you use these items in bed when you can't sleep. And there are actually some ways to properly or appropriately use one of these, and I'll talk about that. And then I don't know how to turn off the blue light on my devices. Daily habits. I would want you to think through whether or not you get enough exercise, whether you smoke, whether you have alcohol, more than 1 or 2 drinks a day, and whether you have them close to bedtime, how much caffeine you have, whether you have that afternoon, and what time you have your dinner. Some people have quite a late dinner, and ideally it would be 3 hours before your bedtime. So you would want to think through those things. And then, do you use sleeping medications? Do you use more than one? Do you use over-the-counters? Do you have a little magical potion? I would be asking you about those things. So in order to treat insomnia, CBT for insomnia is a very structured program. It's usually time limited. There are certain components that are always included, and they include these: sleep education, cognitive restructuring, so restructuring how people think about their sleep and more specifically about their sleep skills, sleep restriction, stimulus control, that refers to how do you use your bed, what is your bed a stimulus for, sleep hygiene, you know, the basics, and then sleep medication tapering if desired once sleep skills are learned, and relapse prevention, always an important topic when you're doing CBT. So for sleep education, I might cover certain topics like these. We all have a sleep system. We all have a wake system. The sleep system should be active about 8 hours of the 24-hour day, and the wake system should be active about 16 hours of the day. And there is, you know, some chemicals in our brain that pay attention to sleep that we pay attention to that involve sleep and wake. Adenosine is one of them, and adenosine is a sleep promoting chemical in our brain, and it builds up over time. So sometimes people are, for example, waking up at 9 a.m. and then getting in bed at 9 p.m. and they really haven't been out of bed long enough. They haven't had their 16 hours of wake time, and adenosine hasn't had a chance to build up enough to make them sleepy. Then we talk about the fact that some personality characteristics are really useful in the daytime and less useful at night. And those are some of the things we talked about a moment ago on the 3P model: being a perfectionist, being a high achiever, being a type A, being a person who always gets things done. Those are great characteristics in the daytime, and they make you very popular with your employer, but they're not so great for nighttime. And then finally, sleep needs change over the life cycle. So people need more sleep as an adolescent than they need as an adult. And in our later decades, 70s and 80s, sometimes we need actually less sleep at night, and we add naps to compensate. So sleep needs do change over the life cycle. And in a nutshell, this last item, insomnia is often considered a disorder of hyperarousal. So the wake system is too active and the sleep system needs to be strengthened. So one of the first concepts that I talk about with the patients that I work with is something called core sleep. And core sleep, you should think of it as the sleep that you must get. And what we always talk about is the fact that there's a lot of research to show that if you are able to achieve 5.5 hours of sleep on a fairly regular basis, your daytime performance won't suffer too much. Now, am I saying that I only want you to get 5.5 hours of sleep? Absolutely not. But if that does happen for whatever reason, chronic insomnia, being on call, there are a lot of being in medical school, you know, there are a lot of reasons why people might have a period of getting less sleep. What I'm pointing out here is that you usually can make it through the day, do what you need to do. Your boss might not know you're a terrible sleeper because you still perform well. And so we're really trying to make sure that everyone is meeting that sort of minimum daily requirement of 5.5 hours of sleep achieved. And why is that true? Because the first 5.5 hours of sleep contain almost all of the deep sleep a person is ever going to achieve, and 2 REM periods. And I'm going to move to the next slide and then come back to this one to show you why that's true. This is what's called a hypnogram. Many of you have seen them, and it's just a graphical representation of a typical night of sleep for a good sleeper. Let's say an 18-year-old, okay? And down the left side, you see the kinds of sleep that a person would get, with W being awake, R being REM. So those blue bars represent REM sleep, and then stages 1, 2, and 3, so light, medium, and deep. Across the bottom, you see the hours of sleep. And so hour 1, hour 2, 3, 4, like that. You can see up to 8 hours. And if you'll notice, there's some wake at the beginning of the night, and then the person sort of stair steps down into the first cycle of deep sleep, represented by that first red circled oval. and then they have their first dream come along, and then they have another nice, beautiful period of deep sleep, and their second sleep REM period, dream period comes along, and then they have a brief waking, you can see, around hour 3. And then around hour 4, they get one more period of deep sleep. And then around hour 4.5, they get their third period of REM, dream sleep. And then around 5 hours and change, they have a waking. If they were to wake at that 5 hours and change mark and wake for the day, they would have achieved all of their deep sleep and 3 cycles of REM. And what they would have missed would be 2 more cycles of REM or dream sleep and lighter sleep. So I often use a food analogy. If you wake after 5 hours and change, you've gotten all of your protein, your deep sleep, and you've gotten 3 of your veggies. You've gotten some complex carbs too, which is the lighter stage of sleep. So if you wake at the 5 hour and a half mark, you've gotten all of your protein, 3 veggies, and some of your complex carbs. And what you're missing with hours 5.5 through 8 are 2 more veggies and some more complex carbs, which would be great to get. But just remember that you've gotten sort of the basics. You've gotten all of your protein and 2 or 3 veggies. So let me go back now. And you'll also notice from that hypnogram that sleep does not need to be uninterrupted to count. So I have a lot of people who will come to me and they'll say, but I wake up at night and so my sleep must not be good and my sleep must not be deep. That isn't true. Everyone wakes 4 to 6 times a night, usually at the end of a dream cycle, but not always. And good sleepers don't even notice these wakings. They just turn over or fix the blankets. But people with insomnia become very focused on these wakings, and that makes the wakings anxiety provoking, and that makes the wakings longer. So your sleep does not need to be uninterrupted to count. That's a myth. And finally, I like to use another analogy, another food-related analogy. So we could get by on fewer calories. Core sleep is sort of like getting by on fewer calories. And most of us, of course, want more and should get more. Now, why do we talk about the 5.5 hours so much and so early in treatment? Because it helps people reduce their concerns about their sleep, which, of course, paradoxically, but you can understand why, improves their sleep, results in them obtaining more sleep. So if someone that I'm working with is expecting to get 8 hours of perfect sleep every night, it's really hard to do that. And they feel behind the 8 ball. But if I tell them that I want them to get 5.5 hours or more every night, that lowers the expectation to a point that just causes their shoulders to relax and their mind to relax. And then they begin getting better sleep because they sort of reset their target goal. So core sleep is a really useful concept for people with insomnia. And again, I always want to wrap up by saying, I am not suggesting that you try to get along on 5.5 hours of sleep on a regular basis. It's just something to lower the anxiety level while we're working on the insomnia. The next aspect that we always talk about in CBT for insomnia is cognitive restructuring. So people who have had insomnia for a period of time have many, many, many negative sleep thoughts. Things like, I'll never be a good sleeper again. I'll never be able to sleep without pills. This is going to be another terrible night. And when those thoughts are the thoughts that are going through your mind all the time, you are indeed probably going to be a poor sleeper. So what we do is we have them become sort of, we call it metacognition. They sort of go up a level and pay attention to thinking about their thinking. How many of these thoughts are they having? How many are they having all day long? How many are they having as bedtime nears? That's the cognitive part of cognitive behavioral therapy. And we ask them to try to substitute new thoughts, which are true thoughts. Things like, I will be sleeping better as I learn these new techniques. My performance will be okay tomorrow as long as I get my core sleep. And these techniques have worked for others and they will work for me. Because of course I've talked to my patients about the randomized controlled trials and all the research that has gone in to this type of therapy. Then sleep diaries are a really important part of treatment, of course, because I need a baseline. I need to know where they started and then I need to show them their progress. So that can be done with this kind of device that I'm wearing myself. This looks like an Apple Watch. It's not. It's a very inexpensive device that I got on Amazon. I got it because I do have patients, right, who don't have all the means that they might wish, and they can't afford a really expensive, Fitbit or Apple Watch. And so this one, which costs $30, works perfectly well, and it can track your sleep. But I am also a fan of having someone, even if they use a device, transfer that data onto paper, because paper, this particular log that I use, can be found by typing in 24-hour sleep log on Google, and it will take you to the North Shore Sleep Center's log, which is this log. And I love it because it's so simple and straightforward. And the way it works is that you put a down arrow. You can see on the bottom, there's a sample with a line filled out, a down arrow when you get into the bed. Down arrow means down into the bed. And then you color a square black. If you're sleeping, leave it blank or white. If you're awake, put an up arrow when you get up. And all of this is filled out in the morning from recall, from guesstimate. Otherwise, these folks would be staring at their clock all night, or having a scratch pad by the bed to write all this down. So it's done in the morning from recall. And then you can see that this person got in bed at 9:30, slept from 11 to 1, was awake from 1 to 2:30, slept again from 2:30 to 7, got out of bed about 7:30, and then had a nap, laid down around 1:20, was asleep from 2 to 3, and got up at 3:15. So when you get a whole row, 14 rows of data from someone, that when you see them in follow-up, they might look something like this. So this is a patient that I worked with in April. She has her down arrows there when she went to bed. She has her up arrows when she got up. And you can see that she's in bed a good bit, as early as 8:30 till as late as 7 a.m. So she's, nearing 11 hours in bed. She has gaps of wake. She has some nights where she's awake for almost 3 hours before she goes to sleep. Her bedtimes vary a bit, 8:30 to 10:30, if you start to unpack this. And then her rise times are all around, between 5:30 and 7. So this would be a diary that someone might bring me after 2 weeks. Where we would meet, and then they would come back in 2 weeks, and their diary might look something like this. And then this would really give me a lot of ideas about where to go with their therapy. And one of the things I might do, and you might have guessed that from this person's log, is something called sleep restriction. It's a horrible term. So usually I call it sleep scheduling, which sounds much nicer, but it does involve being in bed less. So you basically work with the person to have them in bed less time until their sleep efficiency, very simple to calculate, is 85%. So your sleep efficiency is how much time you're asleep over how much time you're in bed, or how much time you allot for sleep. So if you're in bed 8 hours, but you're only sleeping 6, your sleep efficiency is 75%. And almost all people with insomnia are in bed a lot more than they're sleeping. So what I would do if I went back to this person's log is I would count up how many hours she's actually sleeping and how many hours she's in bed, and do some adjusting. So for example, if this is not true for that particular patient that I just showed you, but I see lots of people who go to bed around 9 and don't get out of bed until 8 in the morning. That's 11 hours, and they're only asleep maybe 5. So that sleep efficiency is terrible, right? 5 hours over 11 hours is not a very pretty number. And so I would work with them to see if they would be willing to be in bed much, much less. We never sleep restrict under 6 hours. So we never put people, I have many people who say, I only sleep 4 hours a night. Well, I've never put them in bed only 4 hours. I would always have 6 as my minimum. And then I would increase that number as efficiency improves. And 6 hours obviously isn't the number of hours for everyone. Oftentimes I'll see people who are in bed about 9.5 hours, and I might work them down to be in bed only 7.5 or 8, something like that. That would be more typical. And then I would ask them to keep their bedtimes and rise times consistent within a 1 to 2 hour window, no matter how much sleep is obtained. So I would be asking them to get up, let's say between 6:30 and 7:30, no matter what. And then they can add a nap between noon and 4 p.m., ideally, if that's possible, and for less than an hour if their sleep was very poor. If they got less than core sleep, which you know is 5.5 hours, then the prior night. Now, this idea of sleep restriction is not a popular one among people with insomnia because they feel like the more time they're in bed, the more opportunity they have to sleep. So I've come up with an example to explain why it works. And I use, believe it or not, a submarine as my example. And here's what I mean by that. Some of you have probably toured the submarines in Groton. I know I have. They're really interesting to tour. And they have things called hot bunks. And that means that there aren't enough bunks on a submarine, of course, it's too tiny, for everyone to have a bunk. And so these bunks are shared. And they're called hot bunks because when you get in yours, someone just got out of it. And so what I'll say to them is, I want you to imagine a submarine where the service people have access to a bunk for 12 hours. And then they have to be out of their bunk for 12 hours, versus a submarine where they have access to the bunk for only 6 hours out of a 24-hour period. So they have to be out of their bunk for 18 hours. And I'll say to them, who do you think is a better sleeper? The person who spends 12 hours in bed or the person on that submarine who only can spend 6 hours in bed? And pretty much to a person, they will get the answer correct. And they will say, the person who only has 6 hours of opportunity, 6-hour access to a bed, they'll be very, very sleepy and they'll sleep really, really well. And that is true. If you've been awake 18 hours, working and moving around the submarine, and you only get access to your bunk for 6 hours, you are not going to fool around and do anything else in that bunk. You're not going to go on your phone. You're not going to bring food there. You're not going to talk to anybody. You're going to get in your bunk and get right down to sleep. Because 6 hours later, someone is coming to take your bunk. So people really understand that example. And I've landed on that because people very intuitively and very quickly understand with that submarine example that less time in bed can actually be a useful thing to improve and deepen your sleep. And the other reason that people understand that example is that the concept that is really paramount in CBT for insomnia is the idea of stimulus control. And by that, your stimulus is your bed, and we're controlling how you use your bed. Your bed it's my job, my primary job, to reassociate that patient's bed with sleep and relaxation only. And of course, you have to think about Pavlov for that, right? He proved that if you ring a bell, when you feed a dog over and over again, the dog will salivate to the sound of a bell. And what I'm always pointing out to them is if you've associated your bed with worry and wakefulness and anxiety and bringing food there and problem solving and frustration and reading your emails, well, pretty soon your brain won't know what to do in the bed. It won't know that you want to sleep there. Your brain has seen over many months or many years that you use your bed not just for sleep and relaxation, but for all these other things. And so that is really one of my primary goals, to reassociate the bed with sleep and relaxation only, so that the person with insomnia does not have dread of their bed, does not have anxiety as bedtime nears, and so on. So how do we do this? We limit activities in the bed to relaxing activities until you're drowsy for a short period of time, so you can get in bed to read, for example, or listen to a podcast or something like that, or sleep. And then I ask them to think about making sure that their bedroom and their home have 3 zones: one for sleeping, one for relaxing, and ideally one completely out of the bedroom for work. Although I see a lot of students, and so they might have to have their desk in their room, but they should at least have their desk for work, their bed for sleeping, and then maybe again, for a college student, maybe a beanbag chair for hanging out and relaxing. And then you want to help people avoid, lying in bed trying to sleep. So a lot of people will say, I'm in bed and, I'm staying there because at least I might fall asleep there. I'm going to try to sleep when I'm there. And at least I'm resting. but they're not really resting. They're worrying, they're frustrated about the fact that they're not asleep. So time awake in the dark is not good time. You don't really want to have a lot of time awake in the dark without any lights on in your bed. And I have a little phrase here, remember the cash price study. And I love this study because it's a real research study, and it's also really funny, and people remember it. So the study goes like this. Researchers took wonderful sleepers, they put them in a sleep lab, and they said the first one of you people to fall asleep gets a big cash prize. And you can imagine what happened, right? The people who were in the sleep center could not fall asleep, even though they were fantastic sleepers. Because when you really have pressure to fall asleep, or you're lying there trying so hard to fall asleep, it doesn't come, sleep doesn't come. So lying in bed trying to sleep is not a good plan. You can also talk to your patients about going to bed only when drowsy, but then not delaying once they are drowsy, right? Because if you do delay to make some more lunches or wrap up something, then you might get a second wind. And once you get a second wind, then it might be 2 more hours before you get drowsy again. It's fine to go ahead and get in bed when you're starting to feel drowsy and to do something relaxing for 10 or 20 minutes. It's also fine to do that again when you wake up. So let's say you wake up, you might have to go to the bathroom. It's fine to do something again for 10 or 20 minutes if you're unable to get back to sleep after any waking. If you think that it's going to take you more than 10 or 20 minutes to get back to sleep, there's a rule, a concept called the 20-minute rule, and that means that you would move to another place in your home, ideally really near your bed, to go and do something quite relaxing and distracting until you're drowsy, waiting for drowsiness to return, and then going back to bed. So I talk to my patients about having a place prepared, a really nice place prepared, because no one wants to get out of bed in the middle of winter in Connecticut. And so that might be a chair with a footrest, soft lighting, right, a reading light, blankets, a warm drink that's already prepared in a carafe, maybe with a cup nearby. And then what I call a bedtime basket. Bedtime basket is a basket of things that you would be willing to do in the middle of the night that you find interesting and relaxing. Books, magazines, podcasts, audiobooks, drawing pads, anything, puzzle books, crosswords, whatever you want. And then when you're drowsy, you would come back to bed. So when I do see patients, I do let them read. When they get in bed, they can read in bed for up to 30 minutes. And if they wake up at night, go to the bathroom and come back to bed, they can read again for up to 30 minutes. But if they're quite wide awake, I actually then want them to, if they've tried for 30 minutes, to move away from their bed to this comfortable spot until they're truly drowsy, because I don't want to associate too much wake time with their bed. And here's where I usually mention that exception that I mentioned earlier to electronics. Being out of the bedroom. I am a fan actually of Kindle, e-reader, Nook, whatever kind. You can use the Kindle app on your iPad or your phone. I would want the person to put it on the night setting, which is the black background with the white letters. Dim down the white letters as much as you can while still being able to read comfortably. And you can use that device in bed. That's actually a perfectly good device to use in bed, in my opinion. It's just really an electronic book. It doesn't have notifications, email, social media, anything else. So that's a really good choice, I think. So just to dive into electronics here fully, this is a contract that I give almost every family I work with, and especially if they have kids. And I found this contract on commonsensemedia.org, and I love it because the first paragraph talks about why it's a great idea to use electronics less in the evening, what you can do instead, and why. The second paragraph talks about why it's not good to have electronics, right? They interfere with sleep. The light from the screens makes our brain think it's daytime. And when we bring these devices into bed with us, we're bringing into bed with us phone calls, messages, notifications, games, and so on. And if your child is in middle school or high school, you're also possibly bringing in cyberbullies right into their bed and bedroom. So, excuse me, these smartphones and tablet computers are not terrific things to be associating with your bed. And that goes back to that concept of stimulus control that we talked about earlier. You really want your bed to be a stimulus for None of those things, right? None of those messages and notifications and so on. And then it has a little ending portion where we make an agreement to use the night mode from dinner time till breakfast time, turn our devices off 1 hour before bedtime and leave them off, and then charge them. You know, this is aimed at kids, this particular contract, but leaving your devices overnight in our parents' room or in the main living area of our home. And the earlier you start this with your kids, and the earlier your patients start with this with their kids, the better. Kids are getting cell phones really, really earlier and earlier now. And it's really smart to model this and to start it really early. Because if you have a teenager, you know what a slippery slope having a phone or tablet in the bedroom is. And then we want to talk about sleep meds. They're tapered only after great sleep skills are acquired. I often use a very, very slow protocol. It's a 14-week protocol, and it's 14 weeks per medication. I see many patients on more than one sleep medication. And we use this really gradual protocol to avoid side effects and the anxiety that's associated with a too rapid taper. You certainly don't want to have rebound insomnia. And so we use a very gradual taper. And then once we're completely finished and we take our time, the goal is something called the rescue protocol. And that means using a sleep med only after 2 poor nights of sleep in a row. So if Sunday night is poor night, Monday night often isn't a poor night because of sleep debt. And the person gets pretty good sleep on Monday night. But if they don't, if Sunday night is poor and Monday night is poor, then Sunday night is poor and Monday night is poor, Tuesday night would be a night for the rescue protocol. And they could use their sleep medication that they have stashed in their medicine cabinet that third night, Tuesday night. And you can see that this protocol is really elegant because you would not use a sleep med more than twice a week with this protocol. So it's a wonderful protocol because it gives the patient a feeling that help could be used. You know, a rescue net could be placed under me after 2 poor nights of sleep, but it doesn't allow you to use sleeping aids more than a couple times a week. If you do the math, right, you would, if you had a poor night Sunday and Monday, you'd use it Tuesday. If you had a poor night Wednesday and Thursday, you'd use it Friday, and then you're almost through the week. And again, usually if you have one poor night, the next night is a bit better. So it's just a great protocol. And then of course we have to do relapse prevention as we're wrapping things up. So relapse prevention has several steps: setting realistic expectations that sleep, waxes and wanes. Stressful events can cause insomnia to recur. And then we make a master coping list together. The patient and I, we put together a list. I use Google Docs a lot now for this, of all the things that have helped them through the treatment so that they won't forget all the great things that they learned. We might talk about upcoming high-risk situations. Maybe somebody's getting married and maybe they are going to have to move a parent into another living situation. So we all know, things are coming up that might trigger an insomnia episode. So we talk about that. And then of course, booster sessions are always available if someone needs that to get through an insomnia relapse. And now here we are back to Sarah. So Sarah was really bright, really motivated, and she did great with CBT-I for insomnia. She used her sleep diaries. She kept them religiously. She agreed to do sleep restriction and stimulus control. We tapered her sleep meds one by one using calendars to track her progress, because 14 weeks, it's easy to lose track of where you are in that protocol. And then she finished her treatment with only one over-the-counter sleep aid as her rescue protocol medicine. We talked a lot about the importance of avoiding additional med seeking, because you're sort of always chasing that rainbow, right? You're chasing that unicorn sleep med that's going to work for you, and they're hard to find. Most people, again, of course, get acclimated to that, sleep med, and it stops working. She added a lot of new relaxation skills to her repertoire. And then we made that master coping list of techniques that had worked for her. So now, how can you improve your own sleep? These are the slides that I use to wrap up this section. So be sure you do have a buffer between work and sleep. Don't want you to work right up till the minute you jump in bed. Develop a really consistent, relaxing bedtime routine for yourself. You know, if you, again, Pavlov, right? It always comes back to Pavlov. If you do several things in a row every night, the same, your body begins to realize, oh, this is what she does. This is what she does when she wants to go to sleep. So by the time you're putting your robe on and making, you know, your tea to carry upstairs, your herbal tea to carry upstairs, your body knows that it's time. And then be sure not to ignore the drowsy feelings that you know, when you do get them, to accomplish more things, knock off more work, because then you might get your second wind. And then caffeine avoidance afternoon. You can exercise, but not too close to bedtime. Usually about 3-hour buffer is what we're looking for. Avoid napping in the later, you know, much later in the day or in the evening. Naps after dinner, we call that the forbidden zone, because if you nap at that time, you'll really push your bedtime later, usually. You'd want to avoid alcohol or nicotine before bed. You'd want to avoid that large dinner, but you should absolutely have a bedtime snack. That can head off that desire to wake up and eat during the night. It's a very comforting ritual, and you won't be lying in bed thinking, oh, am I hungry? I'm not sure. So I'm a big fan of having a bedtime snack. And then one alternative to a sleep medication, a very natural alternative, is a hot bath. So if you heat up your body, as it cools, you often become sleepy. Almost everyone has experienced this. If you've ever sat in a hot tub, you get really sleepy, don't you? And so if you are able to sit in a hot bath for about 25 minutes, pretty hot bath, when you cool off over the next hour, you often become sleepy. Also, you want to be sure your bedroom is optimized. We'll talk about that in the next slide. Use your bed only for sleep and don't lie awake in the dark. Improve, you know, keep an eye on your sleep efficiency. You want it to be high, a lot of sleep time for the time you're in bed. Have a quiet, distracting activity ready at the bedside, like your e-reader, a podcast, anything like that, audiobook. Remember that everyone wakes at night, and don't let that throw you. That's normal. Don't watch the clock, though. You should set an alarm for the time that you must get up, and then you should just use that kind of rule of reading until you're drowsy and reading again for a few minutes after awakening until you're drowsy again. And then keeping a really regular sleep schedule. The body loves a very consistent, especially rise time. The rise time is the most important one to keep consistent. But if you know any really good sleepers, their bedtimes are very regular and their rise times are very regular. In order to optimize your bedroom environment, you would want it dark. You would want to avoid screens with the exception of the night setting e-reader. Eye mask can be helpful if you have a spouse who really wants the TV on. Blackout curtains can be nice, but don't have to overdo it. Just a reasonably dark room. I have patients that have like taped over every single thing that could ever shine a light, you know, the light on the old VCR machines, everything. So just reasonably dark. Keep your bedroom quiet. You can use earplugs or white noise or a floor fan to mask if you live in a busy area, or you just have any sort of noise issue, you can use those things. If your spouse likes to watch TV and you don't, you can wear an eye mask and ask them to wear a set of wireless headphones so they can hear the TV. Keep your room cool. People do sleep better in a cool room. 68 to 70 degrees is considered to be optimal, and you can achieve that through fans, air conditioners, layers of bedding. And then make sure you have bedding that you like, you know, maybe a really nice memory foam mattress topper, or those pillows that have sort of a little curve in them for your neck. I really like those. And then you always want to address anything that has to do with your partner. You know, does your partner snore? Do they need a sleep study? What about your children? You know, we're going to talk about pediatric sleep, your housemates, your pets, all of those things can be addressed. And then maintain positive sleep thoughts. Remember the core sleep concept to keep your anxiety level low. And then in the morning, those 4 things: caffeine, activity, sunlight exposure, and food will help wake you up. I help people remember it with the mnemonic CAF: caffeine, activity, light, and food. And then it's always great to have a lot of relaxation skills in your repertoire: progressive muscle relaxation, autogenics, yoga, tai chi, meditation, breathing, and most importantly, having a good work-life balance. I have this slide in case anyone ever asks me how much sleep someone needs, and you can see that that is a varying number. So for instance, an adult might require between 7 and 9. You can see in the dark blue rectangle there by adult. And they might need as few as 6, and they might need as many as 10. But the average is in the middle there, 7 to 9. So you can tell that not everybody needs 8 hours of sleep every single night. So here are my takeaways as my final slide. Please try to choose CBTI over sleep meds if at all possible. I would love it if you had CBTI referral info on hand for your patients. Every accredited sleep center must have a CBTI provider. It's a requirement of accreditation. So if you find an accredited sleep center near you, and of course there are many in Connecticut, you will always be able to access a CBTI provider. And then if your patients are asking you for sleep meds in the interim, consider teaching them the rescue protocol. So for example, you might offer them Ambien. Let's say it's a woman, 5 milligrams of Ambien, and you might suggest that she take it only after 2 poor nights of sleep in a row and provide her with only 8 to 10 pills a month. And that is just sort of a great way to bridge the gap until she is able to find some CBT for insomnia. And then if you happen to be somewhere where that's hard to come by, there are some online options now. I do think it's always better in person. You know, you can learn yoga from a DVD, but it's nice to have a yoga instructor, right? And so some of these online options would be Shut Eye, CBTI Coach. That's an app on Apple and Android, and so on. Okay, so I'm wrapping up now the CBTI portion of the talk, and we can switch gears for some Q&A, right?
Yes, Dr. Schneeberg, thank you so much for such a wonderful presentation. I'm loaded with questions myself, but we've got 92 participants out there who I think also have questions on their mind. So feel free to put those in the chat, and as those roll in, we'll incorporate them into the discussion. And we'd like to leave some time at the end because Dr. Schneeberg also has an additional presentation to help us work with children. So we'll leave time for that also in the last 20 minutes or so. Sound right? So the first question I had, what I was wondering about is, can you talk about CBTI training and certification and what that involves? And can anybody do that, or
Yeah.
what's involved with that?
Yes, anybody can do that. And if you go online to the Society of Behavioral Sleep Medicine, you can find all of the requirements for that. And basically you have to do some hours, of course, of classwork and supervision to get that qualification. And I usually say this, but I didn't. The only downside of CBTI is a lack of providers. So, but where we live, of course, that's very, very, you can do sort of a little mini fellowship and get trained. The University of Pennsylvania is really the mothership. So if you go to the UPenn website, you will find a lot of available training. And of course, it's all virtual now. So they have a 2-day training that they run all the time. Michael Perlis, P-E-R-L-I-S, is one of the most skilled and prolific trainers of people in CBTI.
And do you have to be a mental health provider to be able to be certified in that, or can you be like a primary care provider, or how does that work?
Yeah, really mental health provider, master's or doctoral level is what they're looking for. Great.
I am so great. So I skipped in the chat. There's a question, Jane, if you could type the answer in about the availability of the PowerPoint. I think that there's a strong desire to get the information out there. And I know our video of this Grand Rounds will be posted, and Jane can also talk to us about the PowerPoint availability. And another question I had is, can you say a little bit about how you would talk to somebody who has anxiety about sleep prior to a big performance of some kind? So say I'm going to take the MCATs or some big exam, and it's so important that I sleep. And so sleep in and of itself can be so anxiety provoking for kind of the night before. And like, I know I'll do great on the test if I can just get a good night's sleep. What do you tell people about that?
I have the best answer ever for that. And it's
great.
It's a true answer. The sleep that you need, let's say you're going to take a test on a Saturday morning. The sleep that matters are the several nights of sleep approaching that Saturday morning. including Thursday night. So your sleep on Thursday night is much more important than your sleep on Friday night. And we all know this, right? Anyone who's ever pulled an all-nighter knows this, right? You can study all night and take your test and do pretty well, and then you kind of crash because you're burning the sleep, right? You're using the gas in the car that you already put in the car on Tuesday, Wednesday, and Thursday nights. So that really helps a lot of people let go of their, anxiety the night before. You'll still do fine.
Great. It's so helpful. And can you talk a little bit about the bedtime basket? I had been taught long ago that if I were up in the middle and then I should read something really boring and not something interesting or an interesting book or podcast. Is that not true? And then I never really wanted to read that thing if it was in the middle of the night. Yeah.
You said it for me.
Okay.
I have patients all the time who say to me, I heard I should read the phone book.
Mm-hmm.
Really? Because no one wants to read the phone book. But you're right. If you read the most interesting thing ever, right? Like your brand new book by your favorite author, not a great choice either. So I always say, pick a 5 or a 6 on a scale of 1 to 10. A 1 is a phone book. Okay. A 10 is your brand new book by your favorite author. So you'd want to pick a 5 or a 6. And the reason I love e-readers so much is that you can have so many books on them, right? So you might have your favorite author's book on there, but then you might have a biography you've been wanting to read or a nonfiction book you've been wanting to read. And you have so many choices, right?
Mm-hmm.
So I'm a big fan of either having several books in your basket or several books on your e-reader and choosing sort of a middle ground.
Great. Great. So we have questions appearing in the chat first from Richard Francis. Any special tips about patients hooked on sleep meds, booze, benzos, or marijuana, and how to work with those patients?
Yeah, so those are all of my patients, right? Mm-hmm. And so what I do is when I have them fill out that sleep diary that you see, I have them log those things too, and we come up with a little code, M for marijuana, A for Ambien, some other code for alcohol, and then we're tracking what they're doing. And I always tell them up front to pull them into therapy, right? I'm not going to take that stuff away from you at the beginning, right? I'm going to ask you at the end of therapy if you feel that your sleep skills warrant us beginning to work one by one on those agents. So that's exactly how I approach it. What's really funny to me, though, having done this as long as I have, is they'll have all these things, right? And they don't want me to take them, but they're not sleeping well anyway, or they wouldn't be seeing me. Right? So they're so wedded to their agents, let's call them, but those agents aren't even working, are they? Or they wouldn't be in my office. So having said that, I still wait until they've acquired the skills, and then I do them one by one.
Right. That's great. Diana Turner-Edie says, can you comment on strategies for working or communicating with the MD on gradual tapering of prescribed sleep medications when ready for that step?
Yes. So I always say to the patient, it's your provider who's going to do the tapering. It's your provider who's the prescribing person. I'm not meant to be stepping on their toes, but providers actually often taper too quickly, in my opinion, right? And so that causes rebound insomnia, and then the person is really loath to ever do that again. Mm-hmm. And so I really just reach out to them either through Epic, we're on Epic or any other electronic medical record system, or by phone. Often do it by phone, and I'll say, hey, this is what I'm working on. You should feel really good about your patient. She's really working hard in therapy. We'd like to start tapering. How do you feel about that? And we work out a plan together. But my plan is often even more gradual than the provider would have chosen. So they're usually quite amenable to that.
Great. Dr. Gerber writes a paragraph in for her for us, and I'll try to channel Dr. Gerber here, who says, thank you for a wonderful talk. Dr. Schneeberg, it's a pleasure to learn from you, and thank you for the consultations you've done to Silver Hill on this topic in the past. I have a cultural question for you. Do you find that there is a culture in the US, particularly among professionals, of always talking about how sleep deprived they are? Do you think that's always been the case, or is this getting worse? Are there reasons that people like to talk about being sleep deprived, but don't actually do what they need to do to address it?
Great question. Yeah, people see it as a badge of honor, right? I can get by on 5 hours of sleep. Oh, I can get by on 4 hours of sleep, right? Sort of a badge of honor. I'd like to think actually that it's getting better because now we have all of these devices, these wearables are totally the future, right? People have the Aura rings and the Fitbits and the Apple Watches. So they're paying attention to their sleep and they're getting a sleep score sometimes. And so I'd like to think that people are seeing sleep as a valuable commodity and being willing to get it, to put the time into enough time for it. I quickly want to say that some of those devices are not very accurate, and they're confusing for people. So that's one of the first things we'll talk about if they do have wearables that are making them sometimes more anxious. Maybe their sleep score is not very good. So anyway, I'd like to think it's getting better.
Another question I have for you, I've done a lot of work with residency training through the years, and a while back there were these Institute of Medicine recommendations about the amount of sleep that trainees needed to get, but then people graduate from residency training programs, and such recommendations don't exist necessarily for professionals. Is there a point at which you would recommend somebody not be taking care of patients in terms of the amount of sleep that they've gotten, or how do you consult about that?
Yeah, so under 5.5 hours of sleep on a regular basis is a terrible decision, right? That's how the Exxon Valdez happened. That's how the crash happened with the Metro North member going around the corner. That's a terrible idea. And the American Academy of Sleep Medicine is constantly trying to do liaison work with the training boards to protect the sleep of medical trainees.
Great, thank you. So we have another question in here. Any tips on helping with the quote, counting the hours left to sleep when you wake up in the night?
Yeah, so you should set your alarm for the time that you must get up, turn your clock away, and then use your e-reader or audiobook or podcast. And it's all about, your brain brings up these thoughts and your job is to say, shh, we're actually going to read. We're going to read. And if you read, drowsiness has a chance to grab you. If you're doing the math and counting, not so much.
Gotcha. So I'll keep looking at the chat as we go in, but I wonder if you want to talk to us a little bit about helping our kids sleep.
I'd love to. So I'll just advance some more slides on that, okay? And then we'll do more Q&A at the end.
Thank you.
Okay. Here we go. So treating childhood insomnia. It's no surprise to any parent that sleep problems are very common in kids. The National Sleep Foundation did a poll in 2004 and said that 80% of preschooler parents would change something about their child's sleep. And poor sleep leads to all the issues that adults have, but they might be even worse in children, right? Behavioral issues, tantrums, aggression, anxiety, and of course, attention or learning problems. And so what's the solution? In my mind, sleep coaching or sleep training, which is what it's called for kids, from 6 months, about the age 6 months and up, can really, really make a big difference. So the question I always get when I start to work with a parent is, well, maybe my child needs a sleep study before we get going because maybe there's something medically wrong with them. So that can be true. It's not as true as often as you would think. And so here's sort of my little, rubric. This is my rubric. Do they have loud snoring, gasping? Do they sleep with their head sort of arched back? Is there a question of ADHD diagnosis in early elementary school? Because untreated sleep apnea can certainly look like ADHD, because when your sleep is poor quality, you have attentional and behavioral problems. And then if the child does not sleep well, even with parental help, which leads me to the question that I always ask. Does your child sleep fine once they're with you? Because if you have apnea, you're going to have apnea in the toddler bed and in the master bed. But if once the child gets the parental help that they often need and they sleep well, they probably don't need a sleep study before we start sleep training. Some kids do need both, of course, sleep study and sleep training. So these are the kinds of things that parents say to me when I meet with them. My child has always been a terrible sleeper. My child hardly sleeps. My child fights sleep. Bedtime in our house takes forever. And our child is afraid of her room. So we let her sleep in our room. But even so, we're all exhausted. That last one's true because kids are terrible, terrible, restless sleepers. It's kind of why we want them out of our beds. And so if you have your child in your room, she might sleep better, but you probably won't. And then we're trying to move to this, right? Bedtimes of reasonable length, a child who can self-comfort to sleep, child who can stay in his or her bed all night long, and a child who doesn't wake up at the dreaded 4 a.m. So there are 2 reasons that kids don't sleep well. I'm sorry to say that they involve parents. And I'm wondering, just mentally, I'd love you to guess what you think those reasons might be. But just to get to the point, I will tell you that it is staying with children until they fall completely asleep. Lots of parents do it. I totally get it. But why is this a problem? Because if parental assistance to fall asleep is needed at bedtime, kids will need this assistance again after every waking. So whatever you had at bedtime, you want to recreate that during the night. So if your child fell asleep on the living room floor watching TV and you move them later, you might find a child coming back to the living room to turn on the TV in the middle of the night. And if the child fell asleep in the master bed with mom or dad rubbing their back and they were moved to their bed later, the child is definitely going to make a return trip to the master bedroom in the middle of the night. The other reason is granting too many requests after lights out. I have 3 kids and my 2 girls do theater. And so I nickname these callbacks and curtain calls because that's kind of what they are, right? They'll either call you back to the room or they'll make a curtain call out of the room after you thought they were asleep to tell you what they need. So as parents, we think, gosh, if I answer all these callbacks and these curtain calls and I give my child everything they need, surely they'll fall asleep, right? Well, actually, no, it goes back to Pavlov again, right? We're actually rewarding wake behaviors when we keep showing up and delivering things to our kids. Ice for the water cup, checking out the window, another hug from dad. So we're actually rewarding wake behaviors if we grant too many of these requests after lights out. Of course, there are a couple things your kids might need and you want to grant those, but you don't want sort of that endless stream of extra requests. So these things have clinical terms since I'm talking to a professional audience. The first one, falling asleep with a parent, is called behavioral insomnia childhood sleep onset association type. So the child sleep onset association is a person. That's a sleep onset association is also called a sleep crutch. So a sleep onset association could be a parent, rocking, bottle feeding, nursing, being driven in a car, anything. And then the second kind of behavioral insomnia of childhood has to do with those requests, and that's called limit setting type, because sometimes there aren't limits set at bedtime about how many requests will be granted. So I'm especially interested in working with kids who are 3 to 10 years old. That's really my sweet spot. A lot of the sleep training books are for infants and really young children. And so I put together a book and a plan for 3 to 10-year-olds. And these are the 5 steps that I use to help parents sleep train slightly older kids, pre-K and elementary. We prepare the room for great sleep. We use a really specific routine to calm and settle them. We teach the child to self-comfort as we taper away the parent. We limit those callbacks and curtain calls, and we manage night and early morning wakings and decide what to do about them. So we're going to remove some things from the bedroom to prepare it, add some things, and there's some options, and then there's some things you don't need. And what are they? Here we go. So we don't want electronics in the bedroom, and we don't want things that turn off later, because I want your child's room to look and feel the same at 2 a.m. as it does at 8 p.m. I don't want, the stars have stopped spinning and the music's off and it's darker and all that. You want to add some things, a security object, a teddy bear, a blanket, the bedtime basket, the same one that I talked about for parents. I want for a child, it's much simpler, of course. For a child, it might be one book, a picture book, a teddy bear, a toy, and a reading light. And then you might need a gait or motion sensor for the child's room if they come out a lot or if they're a sleepwalker. And then there are lots of things that parents purchase and use in the bedroom to fix these sleep issues, like weighted blankets, essential oil diffuser, sound machines, starlight projectors, meditation music, and even Alexa reading stories. Now, parents will say, I tried all these things and they didn't work. And I'll say, yeah, they didn't work because none of those things are as good as a parent. It really all comes back to that fact. If your child wants a parent to fall asleep, none of these things are going to do. Then we'll have a routine to calm and settle them. The one I picked, the one I put together is just 5 simple steps. Most parents probably do these: a snack, bedtime bite, a bath, brushing teeth, bathroom, and books. I love to end with books because there's a clear end point. When the book's over, the routine is over. You've got to have a way to mark the end point of the routine. You could use a timer or a set number of books. Then you'd be allowing the child to self-comfort with their security object, their book or their toy, their reading light. You would give them 1 or 2 tickets. I'll talk about that next. And then you would allow them to read or play quietly until they're sleepy. And then you would work your way out. You would the parent will work their way out by tapering away what I call anchoring behaviors. So a child will always want to do something that anchors you to them. They'll want to hold your hand or play with your hair, put their leg over your leg, and you'd taper those away one by one. Then you might put a body pillow between the parent and the child. Then the parent would move to a chair would walk to the door, and then the parent can, again, over time, be anywhere in the home. And then for those stalling behaviors, right, the callbacks and the curtain calls, you can use bedtime tickets. They help so much with this. You give 2 little, they can be anything. They can be cards or poker chips, anything. You give them to the child at the end of the routine. They can be redeemed for 1 or 2 more brief requests, and unused tickets could be redeemed in the morning for a really small reward. So if they say, I want to hug dad one more time, that costs a ticket. If they want you to look under their bed, that costs a ticket. And they have 2 tickets usually, and then the tickets have been used. And so you'll know you've granted a couple of extra requests, but not 17 more. And then after that, you would use a broken record phrase. If they ask you for more stuff, you can say, hey, your tickets are gone, but you can read or play in bed till you're sleepy. It's bedtime. Then you figure out what to do at night. So I make a plan for night wakings. If the child's been coming to the parents' room, we make a plan for what to do about that. And then we do always take a look at whether or not there are noise, light, hunger, bathroom issues, or whether kids are waking early in the morning to use electronics when our resistance is low. It's keeping them controlled. So I love it if people keep them off limits till a certain time. And then to wrap up this section, people ask me about teens. And so CBTI can, of course, be used for teens. I'm always suggesting that the sleep schedule is kept consistent. The phrase that we often use is school plus 2. What does that mean? That means if your child has to get up at 6:30 a.m. for school, you try to get them up no later on the weekends than about 2 hours later, if you can possibly do it. So 6:30 a.m. rise time on a school day would translate to an 8:30 or 9 a.m. rise time on the weekend if you could possibly do that. A consistent bedtime routine. And then no long daytime napping. There are tons of adolescents I see who sleep from 2 a.m. to 6 a.m. and then they sleep after school from 3 p.m. to 7 p.m. And that's called bimodal sleep, and it's not a good plan. And then again, those zones in the bedroom that we talked about, working, relaxing, and sleeping. And then in the morning, using those circadian cues to help teens wake up, caffeine, activity, sunlight, and a meal. Finally, I hope all of you would be advocates for starting school later. Teens should be going to bed later or going to school later than they are. Teens should have the latest school start times, not the earliest as they do now. And now we're back to Q&A.
Thanks again, Dr. Schneeberg. That is so helpful and so important for lots of us and for the people we take care of. This is such a common issue. We have a couple other questions in the chat from the first part of the talk that you gave around adults.
Sure.
We have a question that says, what techniques do you teach patients who use their nighttime awake time to problem solve, perseverate, ruminate, etc.?
Yeah, perfect question. So what I have them do is I call it a download, right? Everybody knows what that is. So before they go to bed, not in their bed, they would do a download of what are all the things I need to think about or work on. They might even have a journal just for that. Might even have tabs, what do I do about mom's health? What do I do about college funding? What do I do about whatever it is? I need a new job. And you might even have sort of a tabbed journal sort of setup where you really sit and do some functional worrying time, right? We call it worry time, right? So you're setting that aside, and then you start getting ready for bed. And then you put a nightpad on the bedstand for any brilliant thought your brain gives you, either at bedtime or in the middle of the night. You can write it down quickly on the notepad, and then you can address it the next day during your constructive worry time. Then otherwise, if you're in bed, you should be either reading or sleeping. That's it. Or listening to a podcast or an audiobook or any of those bedtime basket items. But I go with over this over and over with them. Your bed is never, ever, ever a good place to problem solve, right? No one makes great decisions at 2 a.m. in the dark. They don't. So that's not the time to be doing that work.
So I have a pad there next to the bed just in case
Yep.
the brilliant solution comes to me, but it's not the place that I'm going to solve life's problems.
Yes, it's Scarlett O'Hara. I'll think about that tomorrow, right?
Yes.
You
Yes.
put it on the pad. Yeah.
Great. Another question here. Can you say a little bit more about snacks during the nighttime and whether they're helpful or not helpful?
Yeah, they're not helpful because they set a tummy alarm, right? You can absolutely train yourself to wake up and have pizza at 2 a.m., but do you want to train that, right? You don't want to groove a pattern that doesn't work for you. So absolutely have a bedtime snack, absolutely. And then just water or herbal tea until morning, right? Now, there is a whole syndrome called night eating syndrome, which is it's actually classified as an eating disorder where people have almost all of their calories at night. And they're very good eaters in the day, and then they really binge at night. So that's its own category, and that takes special training to deal with. But as a rule, no eating at night.
Great. We have a question here from Meg Weissman, who asks, why is it so hard for the schools to set up the later times and schedules for adolescents?
Meg, if you have an answer for that, you would solve a problem that we all struggle with. It has to do with babysitting duties for teens, for younger kids. It has to do with work schedules, after school jobs, sports. There's a million bus schedules. There's a million reasons. We in the sleep field always think those issues are overcomable, right? There's ways to manage all of those. And so we're always looking for advocates to help us in each community to start those school times later for teens.
Great. Great. Can you mentioned television at one point. Can you say a little bit more your thoughts about whether the TV should be off when people are going to bed or how people should think about that?
Right. It should be off, but I live in the land of realism, right? And some people are married to a spouse who has a sleep onset association, to use that phrase, right? A sleep crutch of the TV. And they're stuck with a spouse who wants to watch TV in bed. So if that's true, you can manage it with the headphones for the spouse who watches TV and the eye mask for the spouse who doesn't want to. But in a perfect world, I would not even, honestly, I don't even want a TV in the bedroom. I wish that were always in, another room in the home and someone was using the bedroom only for sleep and relaxation and reading. In a perfect world.
Yeah, great. Any final thoughts you want to leave us with to help us all?
I don't think so. Just protect your sleep and help your kids to become great sleepers from an early age and be good role models with electronics.
Great. Well, thank you, Dr. Schneeberg, for absolutely wonderful presentation that's so relevant for all of us. Thank you to all of our attendees for joining us. As a reminder for folks wishing to receive CME and CEC credits, please complete the evaluation survey that will automatically pop up in the browser as our webinar ends. And we are going to go ahead and conclude our grand rounds right now. Again, thank you, Dr. Schneeberg. It's so appreciated your presence and help today. And thank you to everybody who's joined us.
Thank you.